Your student pre-membership program was research assistant for this one guy. Oh, yeah, I'm
Good afternoon, everyone. My name is Arthur Schafer, and on behalf of the U of M Center for Professional and Applied Ethics, I'd like to welcome you all to our forum on MAiD. Are we going too far, too fast? We have two speakers today, two panelists, and I'm going briefly to introduce each to you, and then I'll make a few framing comments about the whole MAiD debate and controversy. Then I'll ask John Myers to speak, and then Kim Wiebe, and I hope we'll have at least 30 or 40 minutes for discussion, questions, comments. That's the plan. So let me begin by introducing John Myers on my left. John is a barrister. He practices with a firm called Taylor McCaffrey. He's litigated cases in front of Queen's Bench Court, or now King's Bench Court, Manitoba Court of Appeals, and the Supreme Court. But John has been, perhaps more relevantly for our discussion, John's been involved in and honored for his public interest advocacy work and his work on ensuring the rule of law and access to law. So he's been involved in MAiD litigation, and he's going to be able to talk about some of his experiences litigating cases and what he anticipates the future might bring us. So we're very pleased that John could bring a legal perspective to our discussion today. And our other speaker is Kim Wiebe. Dr. Wiebe is the medical director of the Manitoba MAiD team. So I think it's fair to say that she probably knows more about MAiD and MAiD provision in Manitoba than almost anyone else, and MAiD in Canada as well, because the MAiD providers in each province coordinate with each other and go to meetings and so on. So we're very pleased to have Dr. Wiebe with us. I should perhaps mention that her medical training was in internal medicine and critical care medicine, but she then branched out into addictions medicine and public health and palliative care. Palliative care, I suppose, arguably being the most relevant to some of the issues surrounding the medical assistance in dying, since some people regard it as part of palliative care, others regard it as distinct from palliative care. At all events, we're very pleased to have John and Kim with us today, and please give them a warm welcome. So there's lots one could say, many different stories one could tell about to provide a framework for our discussion today, but I thought a reasonable place to start would be 1974, when the government of Canada legalized suicide, took suicide out of the criminal code, but left in the criminal code as an offense punishable by up to 14 years in prison, aiding, assisting, abetting, or counseling suicide. So that's 1974. Jump forward 8 years, 1982. The government of Canada passed the Charter of Rights and Freedoms, which turned out to have a big impact on the story we're going to be telling, John in particular, but also Kim. So the Charter of Rights and Freedoms, it's been many hours talking about it. I'm just going to make three brief comments. In Article 7, the Charter guarantees as a fundamental liberty of Canadians liberty and security of person and self-determination, autonomy. So the right to liberty, the right to bodily security have both been involved in the MAiD legislation, as we'll see in a moment. And then Article 15 of the Charter, the equality clause, or as you might think of it, the non-discrimination clause, says that if essentially guarantees one's right not to be discriminated against on various grounds because of one's religion or one's race or one's disability. And several of the critically important MAiD cases involved the claim that failure to provide medical assistance in dying was discriminatory, in particular against the disabled. So Article 7 and Article 15 have both figured prominently in legislation. But also critically important is Article 1 of the Charter, and John will sure be talking more about the points that I'm making very briefly now. But Article 1 says that these are, what follows are the fundamental liberties of Canadians, but it also says that none of them is absolute. So your right to liberty, your right to various kinds of freedoms that enumerated is subject to reasonable restrictions in a free and democratic society. So the government can limit your liberty, but if it does through legislation, through criminal law that says you can't do this and you must do that, the government can restrict your liberty, but in order to do so, it's got to satisfy the burden of proof. It's got to show that the restriction is reasonably necessary. And so I mentioned that in 1974, the government passed a law legalizing suicide, but left in the criminal code the offense of assisting suicide. Well, now from 1984, Charter of Rights and Freedoms, jump forward to 1993. The case of Sue Rodriguez, a patient, a woman with ALS in British Columbia, patient, who said, this law that prevents assisted suicide is discriminatory against people like me because I'm not ready to, I could kill myself now, right? Suicide's legal, I'm a competent adult. But I'm not ready to die now. And by the time I'm ready to die, she argued, I'm not going to be able to kill myself. I'm going to need assistance. So you're really discriminating against disabled people. She also claimed the right to autonomy. This is an important life decision. I should be able to make this decision. The government of Canada argued against Sue Rodriguez. They argued that the restriction on assisting suicide, the prohibition on assisting suicide, was a reasonable restriction because it was necessary to protect vulnerable Canadians. The frail, the elderly, the disabled, and the thought was that that's a legitimate function of the government to protect the vulnerable. This case went all the way from the British Columbia Supreme Court. That's really their court of, that's their trial court that they call it the Supreme Court. Went from there to the British Columbia Appeal Court to the Supreme Court of Canada, and in February of 2015, the Supreme Court I've now conflated the next. So let me go back. So the Rodriguez case was decided in 1993. The Supreme Court heard the arguments and split 5-4 against Sue Rodriguez. And it's important to remember, though, in 1993, physician-assisted suicide and mercy killing although they were practiced under an informal arrangement in the Netherlands and in Belgium, they were illegal everywhere in the world, everywhere in North America, everywhere in Europe. It wasn't until the next 10 years, 1997, physician-assisted suicide became legal in Oregon. 2002, it became legal in the Netherlands and Belgium. So there was no, when the Supreme Court made its Rodriguez decision, there was no empirical data. The government said, oh, we need to ban assisted suicide or mercy killing. We need to ban it totally, because the alternative is that vulnerable Canadians will suffer, will die unnecessarily, they'll be abused, they'll be mistaken, and so on. The Supreme Court divided. Some thought that the government had made its case, had met the burden of proof and shown the restriction to be reasonable. Others thought it hadn't. Well, now we skip forward to 2015, because there's a second challenge. So Rodriguez is 1993. 2015, another challenge gets to the Supreme Court, and this is called the Carter case, and I'm sure John is going to be talking about it, so I'll just make a couple of brief comments. In Carter, what had changed was there were, I must be one of the few human beings in Canada, maybe the world, who's read all the expert witness testimony, but it was thousands and thousands of pages of sociologists and physicians and psychiatrists and psychologists testifying and presenting the data on this issue. If you want to protect vulnerable Canadians, you have to ban MAiD, physician-assisted suicide and mercy killing, or can you regulate it, allow people to choose it who need it, and still protect the vulnerable? And Madam Justice Lynn Smith of the British Columbia Superior Court ruled that the ban on MAiD, the ban on assisted suicide and mercy killing, was unnecessary, that the government didn't meet the burden of proof, didn't show that it was necessary to protect, that vulnerable Canadians could be protected at the same time as those who were suffering grievously and intolerably from irremediable illnesses were allowed to make a choice to have assistance and die. That was her decision. It got to the Supreme Court, and the Supreme Court gave its verdict in February of 2015, and they ruled unanimously against Canada's law banning or prohibiting physician-assisted suicide, and they set out some guidelines. I won't tell you what they are, but John and Kim will be discussing. And they gave the government 6 months to pass legislation to change the law. The law is unconstitutional. It violates fundamental liberties, and the government hasn't got good evidence. That was what the Supreme Court ruled, mostly based on the testimony that was presented to Justice Lynn in the Carter case. So the government didn't meet its deadline. The Harper government was very unsympathetic to MAiD. Then in the autumn, the Trudeau government came in and said, please, can we have more time? The law was changed. The law was changed on June the 17th of 2016. Mercy killing and physician-assisted suicide were both made legal in Canada. And we've now got some data on how it's working since June of 2016. We've got data for how many patients have used it and who they are and what sex they are and how wealthy they are and what their education.
We don't have that data.
We don't have the wealth?
No, that has not been
sorry.
collected.
Well, there was an Ontario study that I read that examined every MAiD patient in Ontario that did provide. You're thinking of the annual review, didn't you?
Right, the federal government.
Yeah. So, but based on a study that looked at, so it turns out that, well, the last year for which we have data, 10,060 Canadian patients received MAiD provision. They died by a MAiD. That absolute number doesn't mean much, I think, by itself, but I can tell you that it represents something like 3.3% of deaths in Canada were MAiD deaths. So 3% were MAiD deaths, 90% died naturally, that is, without their deaths weren't hastened by, under the MAiD legislation with a MAiD certificate. there's a lot of concern that women would be abused and exploited by legalizing MAiD. Women, after all, who were self-sacrificial and would step forward even when they wanted to live. I mean, it turns out in Canada that more men than women get MAiD. And the Ontario study, to which I adverted a moment ago, showed that the people who are getting MAiD are much wealthier, much better educated, and generally have a higher social status than those who don't. So initial fear was, if we legalize MAiD, it's going to be used to bump off people who are racialized minorities, poor, vulnerable, frail, elderly, confused, and female. But the data from Canada seems to point in the opposite direction and is confirmed by the data from Oregon and from the Netherlands and so on. In other words, our experience, about 3% of deaths, more or less the same as the Netherlands, where it's been legalized since 2002. And more educated and wealthier, more income secure people, confirmed also in Oregon, that was their experience. About 80% have terminal cancer that spread and are dying imminently in Canada. That was true for Oregon, it's true also for the Netherlands and Belgium. Another 14% have cardiovascular disease, and about 10% have respiratory failure, and 5 or 6% have neurodegenerative diseases. So we're talking about people who have grievous medical conditions, most of whom are very near death, and who are using MAiD to have to die with dignity, or to die more easily, or to die with less suffering. That's the evidence so far. But final comment from me before I turn the floor over to John Myers. The federal government's legislation passed in 2016 was quite restrictive. And one of the restrictions was that you wouldn't, in order to be eligible, you had to have a grievous medical condition that was incurable, you had irremediable, you had to be suffering intolerably and in an enduring way, you had to be intellectually competent, rational, decisionally competent, able to make this decision. But the government added what the Supreme Court didn't. In other words, they went well beyond the Supreme Court, restricted MAiD to those whose natural death was reasonably foreseeable. And in 2019, 2020, so the legislation is 2016, 3 years later, it was challenged in court, as of course everyone knew it would be, in a case called Truchon. So Jean Truchon, and it was coupled with another case involving a woman called Nicole Gladue, challenged the law. Neither of them had a natural death that was imminent, but they were both suffering intolerably. In the case of Jean Truchon, he had I'll just summarize by saying they were both in constant, unrelievable pain, and both were severely disabled, and they were refused a MAiD certificate because the government's legislation said natural death has to be reasonably foreseeable. So they went to court, they sued the government for wrongfully invading their liberty. It was a constitutional challenge to the legislation, and they won. Madam Justice Christine Baudouin ruled against them. The government, by the way, had said, well, okay, they can starve themselves to death if they want. And by the way, a number of patients in Quebec and in British Columbia have stopped eating and drinking, either to kill themselves because they were refused MAiD certificates, their death wasn't reasonably foreseeable, or to make themselves so close to death that they were now eligible. The government said, well, they can stop eating or drinking, or they can commit suicide. And the judge said, that's a cruel and wicked suggestion. You're denying them their fundamental liberties. And so she overturned the law, and the government decided not to appeal. She gave them some time to decide, and the government passed a new legislation, and I'm going to stop here. So originally, 2016, we had Bill C-14, then we got Bill C-7, in 2021, and C7 got, well, it didn't exactly get rid of reasonably foreseeable natural death, but it eliminated that as a necessary requirement, and it created a two-track system. And now that legislation has, which had a clause in it that said, even if your sole underlying medical condition was mental illness, you could be eligible if you met all the other conditions, right? If you can be mentally ill, but if you're decisionally competent, you're making a voluntary decision, and you have an irremediable grievous medical condition, can be psychiatric, and you're suffering intolerably, you could be eligible. Well, Bill C7 excludes psychiatric patients, but says in 2 years' time, they will be eligible. There was a sunset clause. 2 years would be March the 17th of this year. But March 17th is going to come and go. The government has changed its mind, and they're delaying implementation for 1 year. John, over to you.
Thank you, Arthur, for your kind words of introduction and for inviting me here today. I've been involved with assisted dying since as early as 1992 in the Rodriguez case. I was co-counsel for a Winnipeg-based disability rights organization called People in Equal Participation. And that organization intervened before the Supreme Court of Canada, asking the court not to strike down the provision that Arthur was telling you about the criminality associated with assisting somebody to commit suicide. And in that case, Ms. Rodriguez had already had a decision in the British Columbia Court of Appeal with a dissent in it that had a pathway for her to receive an assisted death. One judge went along with trying to find a solution for her, but the case before the court was asking for a full striking down. So our client was before the court really arguing that there were significant dangers in striking out the whole provision. But the Supreme Court of Canada wasn't ready at that time, as Arthur said, for a variety of reasons, to read down the provision. Because assisting somebody to commit suicide is still illegal in Canada. And I guess I differ with Arthur. Mercy killing is illegal in Canada, right? You could go in front of a jury and receive jury nullification because the jury refuses to convict you for mercy killing somebody, let's say, in your family. But what the Supreme Court of Canada did in Carter was effectively read down that provision to say, if it's a physician-assisted death in the criteria that we've established, that will not be against the law. So I differ with Arthur a little bit on the terminology there. So our client wasn't there saying, don't give Ms. Rodriguez what she needs. We appreciate the suffering and the concerns, but don't strike out the provision because we as an organization believe that it would be very detrimental to people with disabilities. And the Supreme Court of Canada heard many interventions, and in the end, as Arthur said, it was 5-4 against Ms. Rodriguez. Now, some of you may not be aware, but she was successful in receiving a physician-assisted death, although the details of exactly how all of that happened have never been revealed. I think there's a book out, which I haven't read, unfortunately, but so it's certainly known that she did receive the assistance that she needed. In the lead up to Bill C-14, there was a period of time where individuals who met the Carter criteria could apply to court to receive a Carter exemption order, which protected the physicians, the nurses, the pharmacists, and others on the healthcare team from being prosecuted criminally, because there was this 4-month period where the Supreme Court of Canada gave the government an extension of time to legislate Bill C-14, but said in that interim period, in a 7-2 decision, that those people in Canada who already met the criteria should not have to wait for the legislation. So that's where I came back to this issue in 2016. There were 31 assisted deaths in Canada in the Carter exemption period from February to June of 2016, and there were 3 cases in Manitoba. I was asked by 3 families to assist in securing the exemptions orders from the court at Queen's Bench at the time. And my co-counsel, Alison Fenske's here, she was just teaching at the law school this morning, and she and I took the 3 cases together. I did most of the legal issues that surrounded the case, and Alison was able to tell the stories of the 3 individuals who were before the court, and we were successful in getting the Carter exemption orders in all 3 of the cases. Our first case was the second decision in Canada on the criteria for applying medical assistance in dying. We had the benefit, and our clients had the benefit of the heavy slogging had already been done by Carter. And so that decision established the charter right. All we were doing was saying to the court, everything has been done to satisfy those criteria. Those criteria are met in Carter, and all of the professionals surrounding the family are doing what they're supposed to be doing in order to help the person realize what they were requesting. Since the passage of Bill C-14, there's been no need for court appearances in Manitoba. There were cases, as Arthur said, launched, one in British Columbia, the Lamb case, and one in Quebec, the Truchon-Gladue case, which were combined. So my involvement with medical assistance in dying has really been sort of on the periphery. I helped with some evidence in the Lamb case and a lot of public education activities. So media interviews, doing panels to help the general public or law students or lawyers have a better understanding of what MAiD is about, because people are asking about it. People go to their lawyers and they talk about their wills and their estates and other things like that, and their powers of attorney and their living wills, and they are asking, what can I do? How can I get the kind of death that I might want down the road? What are the steps that I can take? So my role has sort of morphed away from an advocacy role and more into the public education and specific education role. So that's where I am now. And I take pleasure in discussing what the legal landscape is and what some of the issues are and what some of the providers like Kim are grappling with. Because it's always been a very challenging environment right from the get-go to deal with all of the requests that come in and to apply the criteria and to help families through the process. And remember, this is not something that healthcare professionals, contrary to what you're hearing in some places, MAiD providers are not there advocating or promoting the service. It's quite reactive in terms of either patient being referred by their medical specialist or coming to the program directly. So you're hearing very isolated circumstances, and where some folks out there seem to be proactively promoting it as an alternative to different types of care, but that's certainly not the way I understand the program to be operating in Manitoba. Arthur asked me to pick up the chronology of MAiD post the Quebec Superior Court's decision in Truchon-Gladue. And what Justice Beaudoin did in Truchon was to remove a restriction contained in Bill C-14 that was inconsistent with what the Supreme Court of Canada decided in Carter. In one of the Carter exemption cases that was decided prior to the enactment of Bill C-14, the Alberta Court of Appeal, in a case called AG Canada versus EF, held, and this is describing what the Carter exemption was, the declaration of invalidity in Carter 2015 does not require that the applicant be terminally ill to qualify for the authorization. And then the court went on to say, persons with a psychiatric illness are not explicitly or inferentially excluded if they fit the criteria from the Carter decision. In that case, the individual was a woman living with a mental illness that was her sole underlying medical condition, severe conversion disorder, also known as functional neurological symptom disorder. The charter right in Carter, as Arthur was describing it, and simply stated, is a person should not have to commit suicide, which is not legal in Canada, before they are ready to die because they wanted to wait until they were ready and because they would not be able to do so on their own. So the example of that in Sue Rodriguez is she could have consumed enough medication to take her own life had she been able to pick up a bottle and actually put the pills in her mouth and take water. But it was clear with the progression of her ALS that when she was ready to die, she wouldn't have been able to do that herself, and she would have needed the assistance of somebody if that was the form of her suicide that she wanted to take. It was a Section 7 violation to deprive such a person who met the Carter criteria with an assisted death. In Truchon, Justice Baudouin clarified the requirements from Carter, and here's what she said. Carter should not be construed as providing access to any person who meets the Supreme Court of Canada's decisions clear requirements whether or not death is reasonably foreseeable. She also went on to say that the restriction that death be reasonably foreseeable directly interferes with Truchon and Gladou's physical integrity, causes them physical and psychological pain, and deprives them of the opportunity to make a fundamental decision that respects their personal dignity and integrity. Justice Baudouin, as part of her analysis, was required to assess the objects of the provision requiring death to be reasonably foreseeable. And while she found that the object of protecting vulnerable people from ending their lives in a moment of weakness, pressing and substantial, which is what Section 1 of the Charter requires you to do, she concluded that the requirements were not the least drastic means available to meet Parliament's objective. She found the provision to be grossly disproportionate to its objects and inconsistent with the principles of fundamental justice. So that's what Arthur was telling you in terms of the Section 1 analysis. She found that the government's arguments were not persuasive. She determined that the deleterious effects of the restriction on people in similar situations to Truchon and Gladou were disproportionate to the expected benefits of the requirement that natural death be reasonably foreseeable. Justice Baudouin was satisfied that MAiD providers were capable of assessing the capacity of persons who request MAiD and to be able to identify vitiating factors like coercion, external pressure, or suicidality. On the equality issue, Justice Baudouin also found a Section 15 violation. In her view, the requirement created a distinction based on the type and nature of the person's disability, which perpetuated prejudice and disadvantage for Truchon and Gladou and others similarly situated. Here's what she said about that. The type of disability which does not have the effect of rendering their natural death reasonably foreseeable, this prevents them from choosing their end of life where other people just as physically disabled, but whose death is not close, have that option. In the provision, she found that the provision was not justified under Section 1, and as Arthur said, no appeal was taken by Canada or the Quebec government where similar provisions were struck down in the Quebec legislation. In crafting Bill C7, which is the bill that came into force 2 years ago, Parliament was mindful of the fact that maintaining any type of restriction applying only to persons with mental illness as a sole underlying condition that request MAiD would not stand a charter challenge. They knew that. So why bother including it in legislation and putting everybody through yet another court case? But by creating the 2-year sunset clause, which was set to expire next month but is now being extended, Parliament recognized that there would be major challenges that healthcare providers and society as a whole needed to figure out before permitting MAiD to be provided to persons presenting with mental illness as their sole underlying medical condition. So legislation was just recently tabled by Minister Lametti, Bill C-39, and that simply is designed to extend the deadline out for persons who present solely with mental illness as their diagnosis to March 17th of 2024. In the regulatory impact statement, it simply said more time needed to address concerns raised by experts and Canadians about creating safe and consistent assessment criteria to deal with requests in the complex circumstances where the person requesting MAiD's sole underlying medical condition is mental illness. So that's the position that the government has taken. with regard to, and it's not as though the government doesn't have a lot of reporting already. The Council of Canadians produced a very extensive report, the Council of Canadian Academies produced 3 reports on a number of issues that were left after Bill C-14, and one of those reports was an extensive report on what to do when mental illness is the sole underlying medical condition, and dealing with advance directives and dealing with MAiD for mature, what are called mature minors. So in addition to working through the whole issue of how to implement charter rights of persons with mental illness, we still have to deal with MAiD for mature minors. So that's an issue that's still on the table. And keep in mind that mature minors in Canada, those are people who are under 18, the courts have sufficient comfort with their level of thinking and clarity about the issues that they're facing, can refuse blood transfusions and die, refuse ventilators and defibrillators, can refuse chemotherapies, decline food and water, and be allowed to die. So if you're a mature minor, you can die through what are called acts of omission, but you're not permitted to die through an act of commission, which is a MAiD provider providing you a final injection. Request for MAiD in advance directives is another issue that we need to be working through. Many people who see lawyers want MAiD as an option, not only the withdrawal of certain types of treatment or explicit statements not to start certain types of treatment. People want to add MAiD to the menu of options, and that's certainly not permissible in Canada and is fraught with a whole host of issues trying to determine what that person's desires might be years after issuing some type of advance directive. So there are issues surrounding that need to be resolved. And then what about, and this is another charter challenge I'm waiting for, persons with MAiD who end up in personal care homes or hospitals that we describe as abstaining facilities, because for religious reasons, you might be able to get a MAiD assessment done, but you're not allowed to receive MAiD where you are. So if you live in a personal care home that is your home, you would have to leave there to some neutral location to receive the service. So I can see in the future a charter challenge there for people who find themselves in those circumstances. Our discussion, I think, today is going to focus on, and I think our questions that will come for you may be focused on the mental illness question. And I think MAiD providers and the government are really grappling with a whole host of concepts around the assessments that take place for persons who present with mental illness as part of other debilitating conditions or intolerable conditions. But when it's the sole condition, there's so many issues now to deal with in terms of incurability, irreversibility, capacity. How much treatment do you have to show that you've endured before you can demonstrate that this is intolerable to you? And the Supreme Court has said that you're not expected to endure treatment modalities that are intolerable to you. So do we graft on additional requirements? That's what we're going to be dealing with in the future. There are going to be extra hurdles for you to get over if mental illness is your sole underlying condition. And so that's what next year is going to be spent working through, assessment tools, and trying to determine whether the person that's asking for MAiD will be entitled to receive it. To what extent now, right now, it's not a requirement for MAiD providers, although I would expect, at least in my circumstances, there was considerable family involvement and support, but there are circumstances where the person asking does not want their extended family consulted. So in the mental illness category, ought we to go outside that? What are the competing interests of privacy versus reaching out and trying to get a better feel for what that person's circumstances are, what their family circumstances are, and what they've been going through? So these are some of the things that I think we're going to be seeing as this progresses. And I look forward to your questions, because I hope it will stimulate a good discussion. I think I'll turn things over to Kim, who's on the front lines of providing these services and dealing with some of the things that I've been discussing with you so far. Okay, over to you.
Thank you, John.
I'm gonna sit, if that's okay. Because I'm gonna flip through my slides and just pull up the ones that are relevant. I wanted to start off by recognizing that John and Allison helped those 3 patients in Manitoba who had to go to court to get permission for free. They did all that work pro bono. Allison was actually given an award at some point in time for that work. And yeah, so, and the second patient, actually, when she heard that, she said, finally something for the little people, because she was very poor and would not have been able to afford legal assistance. The other points I want to make is, as healthcare providers, we were presented this with no textbook and a legislation that was written by lawyers. And it was very challenging to interpret legal requirements in a medical fashion. And that continues to be a challenge doing MAiD work. I want to start off by focusing on this slide because the important words here are that assisted dying is the situation where a person seeks and obtains medical assistance in dying. This can only happen if a person wants it and asks for it. It can't be forced on anybody. And I think that's getting lost in all of the media and stories that are going around. The other point that I want to make, and I have a slide later, you cannot qualify for help to die due to a lack of housing. It's not possible. So when you're hearing of all of these stories, and we're bound by FIA, we cannot defend ourselves when stories hit the media and it's that a patient had MAiD because of this. We're not allowed to actually tell our side of the story. And it's very much a different side of the story than what's often portrayed in the media. But you cannot qualify for MAiD if your sole suffering is a lack of housing. Not possible. So I'm going to skip around a little bit here. I will very briefly talk about the 2 types of assisted dying that are allowed in Canada, which is unusual. Most other jurisdictions have either self-administered with oral medication, which is the only type of assisted dying allowed in the United States, or they have IV. Canada allows both. My understanding is that the government wanted to try to make it accessible as possible and realized there may be some patients in remote locations where getting a clinician to come up with IV medications was going to be a challenge. But what I want to focus on this slide is the terminology. So a year or 2 into assisted dying being legal in Canada, Health Canada changed the terminology, specifically removing suicide and euthanasia, because it is not considered suicide by Government of Canada, and it is not considered euthanasia in the way that that term has been used in the past. So they specifically changed the terminology to remove those words, and that's important. In terms of the eligibility criteria, there's 5 main eligibility criteria, and this is the same across Canada, and patients have to have all 5. So the first is that you have to be eligible for healthcare in Canada. And this was put into the law specifically to prevent people from other countries coming here just to have help to die. You can be a recent immigrant or refugee and access assisted dying, provided during the waiting period after which you'll be eligible for healthcare. You also have to be an adult, which the law defines as 18 years of age or older, and capable of making medical decisions for yourself. You do not have to be 100% competent to access assisted dying. Capacity to make decisions is time and task specific. You can have capacity at one time, but not another, and for one task and not another. As long as you have capacity for the task at hand at the time of hand, that is sufficient. So you do not have to be 100% capable to access assisted dying. The third criterion is that you have to have a grievous and irremediable medical condition, which has 3 criteria of its own that I'll show you on the next slide. You have to make a voluntary request that's not the result of external pressure. When we meet with patients to do the 2 assessments that the law requires, we always encourage them to have their loved ones with them, but we always ask those people to step out for part of the interview. And during that alone time, we explore with the patient if anybody is pressuring them to do this, if there's any financial pressures, housing pressures, anything that's making them think about dying earlier than they otherwise would. If we identify an unmet need, then we would certainly do whatever we could to get that need met before we would proceed with assisted dying. And then the 5th criterion is that patients have to provide informed consent for an assisted death after being made aware of all alternatives, including palliative care. Anybody in Canada who asks for help to die has to be made aware of the option of palliative care. They don't have to be enrolled or referred, but they have to be aware of that option. The stats, so the feds have been collecting stats on a national level since the end of 2018, and that data indicates, which Manitoba fits with, is that about 80% of patients are connected with palliative care at the time of their assisted death. The 20%, based on our experience in Manitoba, the 20% that aren't connected with palliative care have either declined a referral to palliative care or they're not eligible for palliative care. Because a lot of palliative care programs focus on the final months of life, and you don't have to be in the final months of life to qualify for assisted dying. So there are some patients that are eligible for MAiD, but not eligible to be enrolled in palliative care. Grievous and irremediable, and this is really where the crux of the decision-making happens for us as MAiD assessors and providers. There's now 3 criteria. There used to be 4. So reasonably foreseeable death was the 4th criterion that made up grievous and irremediable. That's now been removed as an eligibility criterion. So there's now 3. And that includes having a serious and incurable illness, disease, or disability. Currently, mental illness is excluded. The serious and incurable condition does not have to be terminal or fatal, and it never has had to be terminal or fatal. It has to be incurable. There is some debate in Canada as to whether refusal of curative treatment equals incurable. We do not take that stance in Manitoba. But you have to have a serious and incurable illness, disease, or disability. A symptom is not an illness, disease, or disability. The second criterion that makes up grievous and irremediable is that you have to be in an advanced state of irreversible decline in capability, which unfortunately is not really expanded upon by the government in Canada in terms of what was meant by this. They have issued a couple of statements saying that it can be static or dynamic, and it can be chronic or acute. So you could be born disabled and be in an advanced state of decline that you've had for your whole life, or you could have an illness that's progressively leading to more and more decline. Most of us doing this work have interpreted this to mean no longer able to do things you used to be able to do, or not able to do things others can do, and requiring assistance of some degree. But patients do not have to be completely bedridden. Okay? And then the third criterion is that you have to have intolerable suffering due to your incurable illness or your state of decline. So suffering due to a lack of housing would not qualify as being due to your incurable condition or your state of decline. And that's why you would not qualify based if that is your suffering, okay? The suffering has to be due to your incurable condition or your state of decline in capability. As John mentioned, the law says that the suffering cannot be relieved under conditions acceptable to the patient. So patients don't have to try absolutely everything available to relieve their suffering. However, most of us doing this work would require patients to try something. And we use kind of the benchmark of what would most people in their condition be willing to try, okay? So the Canadian law, you can correct me if I'm wrong, is the only one that does not have a minimal treatment requirement. Most other jurisdictions require that the physician have agreed that the patient's tried reasonable treatments, I think. Is that correct?
I'm not sure.
Okay. As John said, assisted dying is currently not permitted for minors via Advance Directive living will. You have to have the illness and the capacity to consent at the time of your request. So you have to meet all of those criteria of having the illness, being in an advanced state of decline, and be suffering, and be able to consent. Proxies and substitute decision makers cannot request MAiD and set it up on somebody else's behalf. They can make the phone call to us if the person physically can't call, but all of our interactions have to be directly with the patient. I will say this is the $1 million question that I get asked when I do presentations. Why isn't it via Advance Directive? When is it going to come? I do think that we will eventually get there. I have to say, as somebody who helps people die, it's one thing to help somebody die after meeting with them, hearing from them how they're suffering, talking to them about their alternatives. Why not wait to die from your cancer? Why not die by stopping dialysis? Why not do this? And hearing from them and making sure they know they can change their mind, giving them the opportunity to change their mind at the last minute. That's a very different experience than helping somebody die based on a piece of paper written 10 years prior. I've never met them. I've never talked to them. How do I know that, you know, and what if they're happily folding the face cloth over and over and over in the nursing home and they don't look distressed? You know, like, it's a very different scenario. And I think the government has been correct to pause and think about that and do MAiD for other populations before going there. What I can potentially see happening is if there's a family doctor that's been involved with a patient's care for many, many years, has helped them write their Advance Directive, that doctor may say, you know, John and I have talked about this 100 times. I know this is exactly what John didn't want. I'm comfortable helping him die based on those 100 conversations that we've had about this.
John did a video,
Right.
sat down and said, future caregiver, if these are my circumstances, unequivocally, I say I would not want to be here anymore.
So the advice I give is update your Advance Directive every year so that I have a clear, consistent over time map to follow. Videotape yourself, tell as many people as you can in your circle what you want, make it clear. And put MAiD in your Advance Directive now if you think you want it in the future, because if the law changes and it's not there, then you're screwed. But be totally aware that it is not legal to have MAiD by Advance Directive now. We get like so many calls each week from people asking for it by Advance Directive. And it's also not permitted currently for mental illness as the sole medical condition. A couple points here. Dementia is not considered a mental disorder. It's a neurodegenerative disorder. It does qualify, has always qualified. It's a terminal condition. So dementia has qualified from the beginning. And there have been several patients with dementia that have had assisted dying. The reality with dementia is you have to die while you're in that middle zone of dementia. So you're advanced enough that you meet the criteria, but not so advanced that you've lost insight and understanding of your condition. So it realistically means missing out on some reasonable quality of life in order to have help to die for dementia. And most people that I've met are not prepared to die during their actual window of opportunity, and they miss their window of opportunity. Understandable. And again, I'm not proposing that people have MAiD, but you can, the other point here is that you can have a co-occurring mental illness with a physical illness and qualify. So you can have cancer and depression or ALS and schizophrenia and qualify for MAiD now based on your physical illness, as long as your mental illness isn't impairing your ability to make decisions for yourself. I don't want to spend kind of a ton more time on slides because we don't have a lot of time left for questions. What I thought I would do, I want to quickly go over some misconceptions about assisted dying, and then I wanted to put up 7 cases and talk quickly about that. So common misconceptions: you can have MAiD via Advance Directive, not allowed. Somebody else can make the decision for you, not allowed. There is no cost. Assisted dying is part of the insured healthcare. There's no cost. The law does not require families to be involved. John talked about that. You know, one of the recommendations from the expert panel about that is made recommendations for MAiD for mental disorders. One of their recommendations is that families should be involved, but if the patient refuses, you know, really, and very few patients exclude their family, but really, if you're a competent adult, you don't have to tell anybody what you're doing in the healthcare system. So assisted dying is no different. And then the other point is that life insurance, Canada pension benefits, they all remain intact. It's not considered suicide. When the government amended the criminal code to allow for assisted dying, they at the very same time amended the Canada Pension and Veteran Affairs Acts to clearly state assisted dying is not suicide, all your benefits remain intact. And shortly thereafter, the Life Insurance Association of Canada issued a similar statement saying assisted dying is not considered suicide, it will not affect any life insurance policies. And then, so the last slide that I'll put up is just very quickly, so some cases here. And I'm going to just run through these very quickly. So the first is a 75-year-old gentleman with metastatic lung cancer with bone mets. He's bedridden. Cancer care has given him a prognosis of 1 to 3 months. He's enrolled in palliative care and he's asked for help to die. The second is a 48-year-old female with ALS or Lou Gehrig's disease. She's dependent on a breathing machine and a feeding tube, and she has asked for help to die and is wondering if she can donate her organs at the time of her assisted death. The third is a 24-year-old female with quadriplegia following a boating accident 7 years prior, and she's reached out asking if she can have help to die. The fourth is a 55-year-old female with stage 2, potentially curable breast cancer, who's refusing cancer treatment based on a long-standing history of juvenile rheumatoid arthritis that has left her with significant disability. The fifth is a 95-year-old female with quite severe osteoarthritis with chronic pain, immobility. She has a very unstable knee and frequent falls because of that. The surgeon has said she's not a candidate for surgery due to her advanced age. She recently had a fall that ended her up in the emergency room with a bleed in her head, and she's terrified of having a fall that's going to leave her incapacitated and has reached out asking for help to die. The sixth is an 80-year-old female with dementia in a nursing home who every day says to her family, I want to die, I want to die, I want to die. And her family has reached out asking if this is a possibility for their loved one. And the seventh is an otherwise healthy, quote unquote, 99-year-old gentleman who lives in assisted living, can't see that well, can't hear that well. Most of his friends and family have died. He's reached out saying, I've had a great life. I never expected to live this long. I'm done, I'm ready to go. Can you please help me die? And I'll just quickly say that the first 6 patients are all patients that were approved and received help to die. The 7th did not, okay? And then I think I'll leave it there so we have some time for questions.
Okay, well, thank you very much, Kim and John. And the floor is open for your questions, comments at the back.
Hi, I'm Diane Treasure from Disability Studies here at Wiebe. I teach in that program. I came here today to hear what you folks had to say, but But particularly you students, there is another point of view that you haven't heard, and that is the point of view of the majority of people with disabilities in Canada. I've worked for 40 years with organizations of people with disabilities, Council of Canadians with Disabilities, Disabled Peoples International, Manitoba League of Persons with Disabilities. These are representative groups of people with disabilities. And these groups have fought against MAiD for 40 years in the courts, and I've been part of that. So if you want to learn more about what majority of people with disabilities are thinking, come out to an event on March 1st. It's on Zoom. It's being hosted by the Rady Center, by Community Health Sciences, by Dr. Reg Urbanowski, the Dean. He's hosting it. And it'll be a 3-hour meeting, and there will be 6 representatives, people with disabilities, who have worked on this issue for so many years, who have appeared in the Supreme Courts, have been arguing as interveners, as well as the other interveners that John was telling us about, PEP. I know PEP very well. That was a very small minority voice among people with disabilities at the time. So I just want to say, if you want to hear how people with disabilities are feeling, what's going on, you need to hear. And it's not just about housing. You know, the folks who don't have housing also have mental illness. And because they have mental illness, they may not be able to deal with systems. They may not be able to deal with the bureaucracy. They don't have an address. Yeah, your life would be pretty poor. You don't have supports. A lot of people don't get treatment. We know there isn't enough mental health treatment. And you know, I myself am a person who had 4 chronic illnesses. I could have died 3 times already in my life, but I'm struggling to stay alive and have a great life. I'm a professor, and having a disability is a great life. So
Professor Dreger, I'm going to interrupt. Can people write to you to get the URL for the conference?
Yes.
Yeah. So if you're interested in attending, and your first name is? Diane Dreger?
Dreger, yes.
So if you write to
Diane
Professor Dreger or to me, I'll share, she'll share, or I'll share the URL if you're interested in attending that Zoom conference. And I'm going to interrupt you.
This might be a good time for me to present this slide, actually,
Yeah.
which was kind of the title of today's talk, in terms of whether MAiD is going too far too fast. I would say that in terms of societal values and end-of-life wishes, it's not. In fact, people want it to go even further and be available by advance directives, etc. In terms of societal and healthcare resources, yes. We have a broken healthcare system. If we had a system where people had equal and good access to palliative care, senior care, mental health supports, then I would have no problem with MAiD being available on top of that. It's very concerning to us doing MAiD work that it is potentially easier to access MAiD than it is to access those other resources. And we're all acutely aware of that. So I do think that there needs to be more focus on building up the healthcare system to a robust level in order to ensure that MAiD is being added to a robust healthcare system.
Okay. I'm going to take some more questions now, but I think what I'll do is take 3 or 4 together, and I'll ask each of you to keep your questions brief and pointed, or your comments if you want to make one. So I'll go around the room and take several. Yes, start here.
Yeah, thank you. My name is Mark Clark. I'm in the anthropology department, social culture anthropology, assistant professor there. And I'm here because I'm learning, and this was a great talk, so thank you. I'll really appreciate it. And I'm going to be vulnerable with folks. It's going to be a quick comment and I have a question. So I've been on both sides. My father figure, long time mentor, chose me. He passed about 3 years ago. And then my aunt, who was severely ill, did not choose me, and she passed last year. so I've seen both sides. And my question, just to get to the crux of things, is, you know, is MAiD also a promotion for people? You know, for instance, what I mean by that, because I'm listening to your talk respectfully, and you say you can choose, you can. And I was thinking to myself, would the terminology be better if you were to say a person can do, or a person can choose, right? And I'm starting to think through the moment, particularly with my aunt now, where she was suffering at a point but chose to stay alive. But the doctor was also saying, this is it, you should consider, right? So what's your thoughts on the promotion of MAiD?
Okay, hold that question. I want to take a few more, and then I'll, before we run out of time, I want to give as many people as possible. Other questions? Yes,
So I guess it's more of a.
could you
question
take
for-
your, could you?
Sorry, yeah. So I guess this is a question more for John. I think the criminal code still refers to MAiD as suicide, right? Section 241(1).
No, it's medical assistance in time.
I don't have it in front of me, but,
Well, it's in front of me.
okay.
It still says suicide, and then it lists exemptions. So if MAiD and suicide are not the
Well-
same thing,
Okay, well, assisted suicide is illegal, and that terminology in the base criminal code provision before the cases started probably is still there. But MAiD, physician-assisted death as it was being called initially, are all exemptions to that specific provision on assisted suicide.
right, the provision that includes suicide. So if suicide and MAiD are not the same thing, why the need to have exemptions?
Could you hold your response?
Sure,
I want to take a
sure.
few more questions, and then,
I
yes.
forgot you were wrangling.
Hi, I'm Kirsten Roger. I'm a professor in community health sciences, and I'm teaching a death and dying course right now. So just yesterday we were talking about palliative care and assisted dying. So thank you for providing this opportunity. And I think it's really important that we come together and talk. So hearing all of the ideas and being open is very important to this discussion moving forward. I just have a comment because I do have some concerns about MAiD, and thank you, Dr. Wiebe, just for your last comment about the healthcare system. We do know that the fallout and the economics of MAiD will result in millions of dollars being saved in the healthcare system. So that may not be the law, it may not be your area of expertise or your specialty, thinking about the economics and the fallout of it, but we do know that the economics will be a benefit to the healthcare system more that MAiD is employed and used. So that's a bit outside of your area, but I did want to make that statement, and thank you again for providing us with this opportunity. I think it's important to talk about.
Okay, other questions or comments? Anyone on this side? Yes.
I just wonder what established trainings in trauma-informed care are required for the medical staff who are making these credibility decisions, and for the legal representatives who are, I mean, I'd like to thank you for doing the advocacy work pro bono, you and your colleague, but I think you're probably a minority. And for the most part, there are people losing their houses and going into massive debt so it's no surprise to me that it's wealthy, well-educated, probably white men in Ontario who are accessing these services, no offense. However, so what mandatory trainings are there for lawyers, for judges, and for physicians in terms of trauma-informed care that will avail them these opportunities to see trauma for what it is and contextualize everything that's happening in a person's life who may have already lost their house to cancer treatment care, or who may be reluctant to say they're being pressured if they're experiencing intimate partner violence, etc.
Okay, I can take two more questions and then we'll let our panelists respond.
I have to leave in four minutes.
Oh, okay, well, we'll stop here then. Thank you for your questions and comments, and John and Kim, you want to have a go?
Sure, Kim, why don't you answer anything you want to answer, because you've got to go, and I'm happy to stay for a while and answer questions.
So I think in terms of public awareness. I think it is important for the public to be aware of all options available to them. I will say that that's not happening equally across Canada in terms of letting the public know that assisted dying is a legal and available treatment. There's concerns that because the criminal code it's still a crime to counsel somebody to end their life, it's kind of made it challenging. A lot of people have been cautious about telling patients about the option of assisted dying because they don't want to be seen as counseling them to end their life. But I think what's been clarified in the last few years is that letting patients know about an option is not the same as recommending that they do it. And really the pendulum has swung now that that probably as healthcare providers, we have a duty to inform patients at the end of life about this option, because if they're not aware of it, they're not really making a fully informed decision about their end of life care. But it's presented as an option amongst many options at the end of life with no recommendation. In terms of trauma-informed care, so the requirements would be the same as with any other healthcare. There's no additional requirements. There certainly is a recommendation. The expert panel published 19 recommendations concerning MAiD for mental disorders, and one of them is that MAiD providers involved with patients with mental disorders should be trained in trauma. What's concerning to me as a MAiD provider is that the expert panel recommendations their recommendation is that they should be just recommendations and not actual requirements. And that's concerning to me, because if they remain as recommendations only, then MAiD providers can choose to follow them or not. And certainly in Manitoba, where we've had a quite conservative approach to assisted dying, our preference would be that they're their requirements and not just recommendations.
Just to try and address your
So
point.
hang on, Johnson, just
Okay.
before you leave.
Sorry, I
Oh, you
have to
gotta
meet
go.
a patient at 2:00.
Okay.
They specifically asked me not to be late.
Perhaps what I'll do is, we're just about at the time we announced 1:15 for the end of the session. So I think on your behalf, I'd like to thank both of our guests, John and Kim, for their presentations. And then we can formally adjourn the session. Those who have to leave will make a fast getaway, and those who would like to stay for a bit to continue the conversation are welcome to do so. John and Kim, thank you very much for your excellent presentation.